So the state is they're dropping the mask mandate. Counties are free to keep it going. The number today in LA County, I looked a little while ago, was 4,000 something new cases. That's about 3 days in a row. It's been 4,000. So it certainly seems that we're on the mend. And yes, Rob and I will do that. I'll hit my magic mute all button, actually. But if you guys will mute yourselves, just a reminder. But you can do it after you cheer after my wonderful introduction of Doug here. So anyhow, it seems things are on the downslope. That doesn't mean there won't be another variant out there, but Doug Ebersole was with us a little less than a year ago, and we were talking about COVID and diving and all the various things. Remind you that he is a COVID survivor, I guess is the word to use, as am I now. I got it in October. I had Delta. I just resumed diving a little while ago at the aquarium because we have a 90-day thing there. So Doug's going to bring us up to speed on what's going on, what's been happening, maybe what did we know a year ago that we know now is not true? What did we think is didn't know that now is true? And we'll see how that all plays out. So he's in Florida. We appreciate the fact he's staying up late. So please give a warm Zoom seekers welcome to Dr. Doug Ebersole, please. And Doug, you may take it away.
Okay, great. Thank you very much.
Thanks.
Okay, I'll share my screen here. So this is, it's like Ken was saying, I spoke to you guys a little less than a year ago about diving in the era of COVID-19. So this one is now an update on that. So for those of you who weren't here a year ago, the first question is kind of like, who am I? As Ken was mentioned, I'm a physician. I'm an interventional cardiologist here in Florida. I've been diving for a very long time, very active, diving and instructing. Been fortunate to be on some boards over the industry. So I've been pretty tuned into the industry for a long time. I'm also the cardiology consultant for Divers Alert Network. But importantly for this talk, I am not an infectious disease specialist. I'm not a microbiologist. I'm not a virologist. I don't have a master's in public health. As Ken mentioned, what I do have is I'm just a doctor and a diver who was a COVID survivor from a long time ago. I had this right after the beginning of the pandemic. Basically, a patient in my office in March of 2020, right when this got going, showed up looking very ill. I got him admitted right to our ICU from my office. Turns out he was positive for COVID-19. And despite my N95 mask, I developed symptoms about 10 days later, typical fever, non-productive cough, shaking, chills, and so forth. Symptoms lasted about 10 days and I got better. The important thing was, and this is for anybody who gets sick, I thought I was better after about 10 days. At that time in Florida, all the gyms were closed, so I couldn't really exercise at the gym. So I broke out my rowing machine, which I would normally do for half an hour. And within about 5 or 10 minutes, I was totally gassed. And it took about 2 weeks to get completely back to normal, even though I thought I was fine at rest. So one of the things we'll talk about is making sure before people get back in the water, if they get sick, they need to be back to normal exercise tolerance. But anyway, so that's kind of why I'm talking to you, is because I have to be one of the early physicians who caught this. And as a diver, I started getting lots of questions. And so it kind of became an interest to kind of understand what was going on. So I returned to diving about a month after having the disease. And I've been very active. I mean, in 2020, despite having the disease, I did over 100 dives. I did almost 175 last year. I'm lucky that I live in Florida, and I'm a cave diver, so reefs and caves are available. We'll talk a little bit about this. One thing to do in this pandemic when you can't go where you want to go is find other things to do. I actually took an ice diving course just about a year ago. It's something I'd never done. It was a chance to do something, get some new skills, so I did that. And we have made a few overseas trips, but canceled some other ones, so we could talk a little bit about that. We were supposed to be going to the Maldives in April, but learned that with our trip, if we tested positive on our way to Dubai, we could get stuck in Dubai. If we tested positive in Dubai, we'd be stuck there and so forth. And we learned that on the boat, the one that we were going to be on, if anybody on the boat tested positive, they were going to be quarantining the entire boat at the end of the trip. So we opted for that particular trip to cancel. So we'll talk a little bit about that as we go along too, as to how to look at your vacations that may be upcoming. Okay, quick background just to catch everybody up. Most people know this or may have forgotten this since it's been so long now, but SARS-CoV-2 is actually the name of the virus causing COVID-19. It's a positive stranded RNA virus, which is why they have these spike proteins that the vaccines are going against on the RNA virus. It's very common. It causes about 15 to 30% of the common cold. So there's lots of coronaviruses out there. In the past, there's been two very bad ones. There's the SARS-CoV-1, the one called MERS in the Middle East. The SARS-CoV-1 was the typical SARS virus we all remember. It was started over in China, 2002, 2003. There were only 8,000 cases, of which, though, there's a mortality rate of about almost 10%. MERS was even worse, much smaller cases, thankfully, not very infectious, only about 2,500 cases, but the mortality of that one was of almost 35%. So we got a little lucky with this particular virus in terms of mortality, but it's just been so infectious, it's kind of caught the whole world. Quick slide just on history. So if you guys remember, this whole thing happened when a cluster of pneumonia cases got reported to the World Health Organization in December of 2019. The common exposure was linked back to a seafood animal market. That's when people started thinking about the bats and so forth originally. And they named it SARS-CoV-2. I just checked about 2 hours ago. And as of today, there have been 398 million cases worldwide, 76.8 million in the United States. And there's been over 5.75 million deaths worldwide. And we just crossed over 900,000 deaths here in the United States. So this is continues to be a problem. It's mainly a respiratory illness, as we know, affecting the alveoli, progressing to pneumonia, but it can cause other illnesses. It can disseminate into the blood and cause some other problems, specifically heart and some other vascular episodes. This is a patient from our hospital. This is not the guy I was talking about that got me sick, but it's a similar case. You can tell from the left slide, this is a normal chest x-ray here on the left when he came in. You can see he does have some comorbidities. That's a pacemaker up in his left chest. Those circles in the middle of his chest are the sternotomy wires from his prior bypass. So this is an older guy with comorbidities. And within 24 hours, his x-ray looked like the one on the right. Additionally, if you look above the top circle on the right, in the midline there, you'll see a vertical line. That's an endotracheal tube. So within 24 hours, he had a rip roaring pneumonia and was intubated. This gentleman thankfully did survive, but was on a ventilator for about a month. And that's how rapid this can progress in people who are prone to having problems with comorbidities. Like I said, usually it's a respiratory illness, but it can affect the heart. We've had issues with people showing up with heart attacks. They've had what's called Takotsubo, which is a stress cardiomyopathy. Lots of people have had cardiac rhythm abnormalities. Unfortunately, there's a hypercoagulable state in some people. This occurs later in the disease. I'll talk about that coming up, where the clotting system gets activated. And you can have either arterial clots or venous clots. In fact, I just saw on the news, local news here out of Tampa today, there's a 20-year-old who had COVID who just lost both of her legs. They had to amputate both of her legs about a week ago from this hypercoagulable state. So, and there was the classic thing about a year or two ago of the poor actor, a Broadway actor who eventually succumbed to the illness, but had to have his legs amputated as well. So there's this activated clotting system, which happens in some people. It happens in other diseases like HIV, dengue, and Ebola, and can result either in arterial problems, which we've seen people come in with normal coronaries, but heart attacks or strokes, and then things like venous clots with clots in the legs or pulmonary emboli. So it's a very complicated kind of disease. This slide is the original variant, but I want to show it for a couple of reasons. First off, just to kind of give you a general idea. On the y-axis, the vertical axis is the mortality rate. So you can look at lots of these other diseases that are out there like MERS, Ebola, HIV, untreated, rabies, tuberculosis, and so forth and so on. And that's the mortality rates. And then along the x-axis, the horizontal axis, is this number called the R0 or the R0. The R0 is basically a marker of how infectious a disease is. I want to put this in think about this because we're going to talk about the Delta variant and then the Omicron variant. So you'll see the idea is if you've got an R0 of 1, that means every person who's infected infects one other person. If you can get something below 1, things die out. So you don't have much of a pandemic or much of an infectious problem. If you think back, like when we were all kids, measles, mumps, and stuff, look way over there, they've got R0 numbers of 11 or 15. So it's very, very infectious. Every one person gets infected will infect 10 or 15 other people. Luckily, the initial COVID virus was around 2.7, 2.8. So much more infectious than the common flu, which is a little over 1, but much less than some of these other illnesses. And then we'll talk about that. Remember that this kind of picture a little bit, and we'll kind of give you a general idea of how that changed with Delta and with Omicron over the last year. The other thing to think about is when this first came out, people were saying, oh, it's just the flu. It's not just the flu, obviously. It is not a very dangerous virus in young people, as you can see here, with very, very low fatality rates. But as people begin to age, you see that the mortality starts to skyrocket. And that's why here in Florida, when the pandemic first started, we had a huge problem with nursing homes. We have a lot of elderly people, and you see that the mortality rate for people, once you get into your 70s or into your 80s or more, begins to have a very, very high mortality. Okay, so how do we detect this? The main way to test this, again, I'm bringing this up because if you're traveling, you may need to see exactly what test your particular country is going to require. The most common test, and probably everybody's had this by now, is this PCR assay. It's kind of like a brain biopsy, it feels like sometimes. They're not quite as aggressive with it as they used to be. They used to kind of go up the nose, wait a little bit till you stopped crying. Then we go a little higher, wait till you stop crying, then go a little bit farther back up. Now it's not quite as bad. It's very, very high sensitivity. Sensitivity means that the test will be positive in someone who's having disease. So it's very, very high, high sensitivity right before you have symptoms or right after symptoms. The specificity, which is it being negative in health, is nearly 100%. So if it's negative, you're in great shape with the PCRs. It took a long time to get these back initially. So the FDA then did an EUA, an emergency use authorization for the rapid tests, either nasopharyngeal or a nasal swab. This was not as accurate, and there's been people who've had false positives and false negatives that then have a different test with the PCR. Just realized that the PCR is the more accurate of the tests. It was less expensive and you get the results much faster. In certain countries now, you can get away with the antigen test for admission into the country, but others you're going to require the PCR. And to get back to the United States, you're going to have a PCR test. Antibody testing, most people within 2 weeks of infection will have that, but unfortunately, we really don't know what that means. So if people have antibodies, they are probably protected for at least a short period of time, but it's recommended that even people who have been infected to definitely still get vaccines and boosters, because those antibodies may not protect them much at all, and if even they do protect them, it'll be a limited time that you'll be protected. So even people who've had the illness should get the shots. It's recommended though to wait several weeks to several months, because you can have a very marked response to not side effects, but typical kind of flu-like effects and pain at the site and so forth, like you normally get with lots of vaccines, but it'll be a kind of a markedly increased symptoms if you've recently been infected and have high antibodies already. I put this slide up. This is just kind of some basic immunology. And the reason I'm bringing it up is our immune system is not just the B cells. B cells are the type of cells that make the plasma cells that make antibodies. So we're thinking about how people are doing. We measure things like antibodies, which is what the vaccine trials are doing. But there's a whole different system. There's your T cells, which we don't have a good way of measuring. And they have memory cells as well. So we don't know how much of someone being able to fight off the virus with a second exposure, whether they've been vaccinated or have natural immunity, how much of that is B cell mediated, which would be helpful with vaccines, and how much is T cell mediated. So hopefully people will have these memory T cells, and even as the antibodies wear off, they may still be able to fight off the virus. Again, I'm bringing this up only to show you that it's not only about antibodies and vaccines to fight this off. Okay, the vaccines that are out there, I think we all know this by now. Pfizer, Moderna vaccines are about 95% effective. This again was up until the Omicron variant. Each requires about 2 doses. The Pfizer is given 3 weeks apart. Moderna is given 4 weeks apart. The advantage of the Johnson & Johnson vaccine from a worldwide standpoint is it's a single dose. So in a lot of developing countries and third world countries, it's easy to get a single dose into people. It's harder to get the 2-dose regimen. So this may be very helpful in some other countries. it's not as effective overall, but was very effective against severe disease. So that was good. A most recent article I saw, which came out last month, looked at with the vaccines. This is 2 doses. This is not with a booster. And this is why they recommend boosters. That did have a limited and waning effectiveness against hospitalization and death after about 20 weeks. So that's whatever, about 5 months or so 5 or 6 months, which is why they've recommended booster shots, especially in those who are at high risk or in the elderly. That came out in the New England Journal just last month. So again, that's the rationale behind the boosters. Okay, what about vaccine side effects? One of the things people say is, oh, I'm not going to get the vaccine because it has such terrible side effects. There have been a total, and this is from a lecture I just watched on Monday morning from Mayo Clinic, a virologist up there who's kind of like the world's expert on myocarditis. Basically, he says there's been 8 deaths reported in under 300 million doses of the vaccine. If you look overall, the likelihood of myocarditis, which is an inflammation of the heart muscle, that occurs overall in about 1 in 100,000 doses. For men or women over the age of 40, there have been no cases whatsoever. The people who have had a problem, or at the higher risk, still only about 1 in 10,000, have been males aged 12 to 17. They think this may be partially hormonal related, and it's one of the reasons they've had a little bit of resistance. The risk to benefit ratio of the vaccines for men aged 12 to 17 is not going to be as high as for all other age groups, but still has benefit of the vaccine over not having the vaccine. The Moderna is a higher dose of the mRNA vaccine than is the Pfizer dose, and because of that, there's a slightly higher risk of myocarditis with the Moderna as opposed to Pfizer. There have been cases, there's been data done now on children under the age of 12, but we don't have nothing reported yet. It probably won't be reported till sometime this summer. But at least currently it's felt, and this is from the experts, that for anybody over the age of 12, including the males 12 to 17, that the risks of COVID-19 greatly outweigh the risks of the vaccine. So it's strongly recommended that everybody get the vaccine. Well, then there's people say, this is the naysayers and the people who say, well, these vaccines, they don't work. After all, it can't work if it requires 2 shots and you have to get a booster. That shows it doesn't work. Oh, and people still contract COVID-19 despite that. So why should we take it? Well, the reason you take it is because that's the way all vaccines are. The vaccines markedly decrease the risk of serious infection or death. So yes, you can still get infected. You may have a mild case, but your likelihood of ending up in the hospital or dying is markedly lower. And many vaccines require multiple doses. That's not a blow against the vaccine. We take a flu vaccine annually, and the risk of contracting the flu varies by year, but there's a significant number of people who get the flu despite having the vaccine. It just tends to be not quite as severe. We all know about tetanus shots. You have to get tetanus shots every 10 years. They wear off. The MMR doses for measles, mumps, rubella is 1 to 2 doses. And the shingles vaccine requires 2 doses, and it's still only about 90% effective. About 10% of people can still get shingles despite having 2 doses of the shingles vaccine. So that's just the way vaccines are. They're not going to be a single shot and 100% effective. That's just not reality. But people using that to justify not taking the vaccine just means they don't really understand this whole situation. And here's why that's important. Okay, here's a slide looking at the risk of testing positive and the likelihood of dying by vaccination status. So we had Delta hit, which was very, very bad in kind of the September timeframe. And if you look what happens, the fully vaccinated people in blue, the death rate remained very, very low. However, for the unvaccinated people, the likelihood of dying from COVID spiked with the Delta variant in around September. So unvaccinated people had about almost a 6-fold higher incidence of testing positive and a 14 times higher risk of dying from COVID-19. Again, showing the problem. And I can speak from our personal experience. In about September, we got shut down again for doing any elective procedures in the hospital. We are an 850-bed hospital. And at one point, we had over 500 of our 850 beds were filled with COVID patients. We had 83 people on ventilators, and we don't have 83 ventilators. So we actually had all of our ventilators in use. And plus, because we weren't doing elective surgeries, we had anesthesia machines being used as ventilators and cared for by nurse anesthetists on the floor. So it got that bad here. We've luckily weathered that Delta storm. The Omicron storm hit us again. Not quite as many sick people, not as many people dying, but the problem with that was, again, lots of people in the hospital, but equally important, lots of staff out. They may not have gotten sick enough to die, but every time they test positive, they're out of the hospital for 10 days. So maintaining staff to take care of patients was a problem. And again, we were shut down to elective procedures for about a month and a half, and have just really got going back again on that. Okay, what about variants? Well, when this first came out, the question was, well, all these variants, this is terrible. Well, if you look at it compared to the flu, this actually doesn't have as many variants as the flu. The flu changes markedly all the time, whereas SARS is a little bit less than even the MERS and the SARS-CoV-1 virus. So yes, there are variants. That happens a lot, but luckily it mutates more slowly than even influenza. However, we've had a couple of bad actors over the last couple of years. Initially, we had these sources came out December, January, and September with some variants that, no real change in virulence and so forth. The one from the UK they thought might be a little bit more deadly, but then all of a sudden we got hit with Delta. Delta first occurred in India in late 2020. They finally named it the Delta variant in May of 2021. And by November of 2021, it was already present in 179 countries. It just spread like wildfire. If you remember, that first strain of COVID was about that R naught number of how infectious it was between 2 and 3, so you're about 2.8. The R naught for Delta was almost double that, which is kind of what happened. All of a sudden that took off, and unfortunately, it was a much more severe illness. It was about as contagious as chickenpox. For any of those who remember, who are old enough to remember, times of chickenpox before the vaccine as kids, and how chickenpox just run rampant through a neighborhood once one kid got chickenpox. It actually was a much more serious disease than previous strains. Compared to the other forms of COVID-19 at the time, there was about 120% increased risk of hospitalization, a 287% increased risk of ICU admission, and 137% increased risk of death. And we were seeing that. It was to try to see our ICU nursing staff and our ICU doctors was painful. They're still totally burned out, but at that point they were just, you can look in their eyes, it's like they're doing everything for these patients, and literally everyone was dying. In almost every patient that was in our ICU that ended up on a ventilator died. Now, they would die when they got multi-system organ failure. So that may take a week, that may take a month, it may take a couple of months, but they were all dying. And at that time, 90% of those people were unvaccinated back in the day of Delta. After Delta, we've developed Omicron. Omicron was first described in November of 2021 in South Africa. Its infection rate, if you remember again, that first R naught was about 2.3, and then Delta was higher. Here's an R naught of 10. So basically 4 to 5 times more infectious than the initial virus. That's now similar to the infection rate of mumps or whooping cough. So very, very infectious, like you'd see in kids. And currently, Omicron accounts for 99.9% of cases in the United States. And the reason that the FDA stopped or no longer approved monoclonal antibodies is that the monoclonal antibodies are not effective against Omicron. And with 99.9% of cases being Omicron, that's why they said, please stop using this. We don't have a lot of data on the vaccine with Omicron, but should be available hopefully this summer. And I just saw reported today, literally today on the news, that there's a new Omicron Sub-Variant, and it's now up to about 3.6% of cases in the United States. Hopefully, it'll just be a minor change. But again, that just shows that this thing just keeps mutating on us. Luckily, since it's so much more infectious, the Omicron variant develops less severe disease than Delta. There's about a 91% lower mortality rate. Hospital stays are shorter, and the ICU rate is much, much lower. And the reason they think this is because while it still affects the nasal passages, it's not as effective at getting into the alveoli of the lungs, so you don't get quite as severe a pulmonary disease. So it will cause more cases, especially among vaccinated patients. You can still get the disease despite being vaccinated, but thankfully with that, it's going to be very, very mild. But there is a reinfection rate So having had COVID once, there's about a 5 times higher risk with Omicron that you could get infected a second time, more so than you would have with Delta. So the main problem now is simply just the sheer numbers of people being infected. It's not as bad of an illness in terms of death, not as bad in terms of ICU admission and being on ventilators, but it's just overwhelming the system because we have so many people out of society because they're quarantining because of having of COVID-19. What about treatments? So let's say you're unfortunate enough to get this. What do you do about it? We're going to talk a little bit about some of these specific drugs here in just a minute, but mild symptoms, as we all know, you basically is treated like the flu. You're at home, supportive care, isolate from other people. If you're at high risk of complications, if you've got lots of comorbidities, if you're elderly, it would not be a bad idea to monitor your pulse ox at home, your oxygen saturation on your finger. You can buy those off Amazon because if you start dropping those numbers into the low 90s, or definitely if you drop into the 80s, that's a time you definitely would want to get a hold of a physician. You're probably going to need to be hospitalized. Moderate symptoms, consider hospitalization, be monitored more closely, and then obviously the severe people end up in the hospital. The treatment is based on severity and also the stage of the disease. The virus itself, replication is greatest right before and right after you develop symptoms. So when you have that much of the virus, that's when the things like the antivirals, like the remdesivir or the antibody-based therapies in the past were the most effective. So that's why it's all recommended to be done within the first 5 days of developing symptoms. Thereafter, once the virus itself has gone away, you then get the hyperinflammatory response and that coagulopathy where you can develop clots. So that happens later in the disease. And that's when things like anti-inflammatory medications, immunosuppressive drugs, and anticoagulants or blood thinners can be helpful. So it's depending on where you are in the disease process determines what the mode of therapy is. These are some of the specific therapies. I talked a little bit about these last year, and I'll add the oral medications here in just a second. Chloroquine, hydroxychloroquine, that was a big political thing. Basically, the bottom line is it's not to be used outside of clinical trials because it's not been shown to be effective when studied in randomized trials. Remdesivir does have effective benefits, especially in patients who are hospitalized with pneumonia. So it has been approved for people with severe disease in the hospital, but there's not enough data to recommend it for more moderate or less disease. Convalescent plasmas. I was actually in a trial for this. We were hoping that early in the pandemic that those of us who've been infected could give our plasma, and that could help other people. Small randomized trials didn't show much of a benefit. It did show a little bit of benefit in a large expanded access trial, but the FDA back in August of 2020 said this should not be standard of care. So that's kind of fallen off the radar. Monoclonal antibodies was very effective against earlier strains, was very effective against Delta. Like I mentioned, though, 2 of the 3 main monoclonal antibody treatments that we currently have are ineffective completely against Omicron. The GlaxoSmithKline product is still somewhat effective, but that's the reason the FDA came out a few weeks ago saying not to use monoclonal antibodies because, again, with the high preponderance of the Delta variant, they're just not effective. Some of the later things we use once you've gotten past the initial few days, steroids. There was what was called the recovery trial, did show some reduced mortality, but it really was only effective in the very, very severe people, especially those who are on ventilators, and not really helpful if you weren't requiring supplemental oxygen, so it's not recommended either. There are 2 oral therapies that have been developed, and this looked like it was going to be really good. Don't get me to try and pronounce the names of the 2 drugs that are in the Paxlovid, but Pfizer has the Paxlovid. They got an emergency use authorization back in December based on a randomized double-blind placebo-controlled trial called the EPIC-HR. It's felt that it can be used for mild to moderate COVID-19 in people 12 years of age or older. That's who it was tested in, as long as they weigh at least 88 pounds, who are high risk for progression to severe. These were high-risk people with comorbidities and had to be given again within 5 days because it's an antiviral. And that's when the viral load is the greatest. It did decrease hospitalizations by 90%. That particular product cannot be given in patients who have liver or kidney disease. There's a second product, Merck's molnupiravir. It cannot be given to children because of issues with bone growth. It can also not be given to pregnant women because of the same concerns with the fetus. The problem with both of these drugs, they sound like it'd be really good, is they both have a long list of side effects, interact with lots of other medications. And in fact, don't take too much on this next slide, but just to show you, these are the drug-drug interactions for these two oral antiviral agents for COVID. So if you're going to prescribe these, this is the drug interactions that you're going to have to deal with. These are all the medications that you'd have to be careful with those drugs. So that's probably why they're not really taking off. You look through these, there are lots and lots of medicines that are used a lot, especially cardiac medications, some statin drugs, antiarrhythmic drugs, some over-the-counter stuff like St. John's wort. So just lots and lots of problems. That's probably why these have not taken off really well because of these interactions, but just something to be aware of, and hopefully we'll get some better oral drugs because that would be very, very helpful in the future. What about long COVID? We actually have one of our internal medicine doctors at my clinic. We're a clinic of about, I don't know, 250 doctors or so, multi-specialty group. And one of them has gone to treating nothing but long COVID. This is some of the first data that came out. This is the 6-month consequence of COVID-19. This is 1,733 of about 2,500 patients in Wuhan, China, back in early 2020. And what they found was that 6 months out, there was still 63% of people were complaining of fatigue or muscle weakness, sleep difficulties in about a quarter, and anxiety and depression in about a quarter. Mainly, this was limited to people who had the most severe disease or who had pulmonary problems demonstrated on chest imaging on discharge. They then looked at 1 year of data, and this is 1 year after hospitalization, again from Wuhan, China, because they had the earliest data. About 45% of people 1 year out were still having at least some symptoms, things like fatigue, sweating, chest pain, anxiety, myalgia. And again, older patients and more severe disease were associated with the highest risks. So COVID can be bad initially, but also can have long lingering effects. We don't really know what causes that, and there's not a lot of good therapies other than supportive care, and just kind of hope that people get stronger.
Hey, Doug, a quick question on the long COVID
Sure.
definition, because I hear people say, well, long COVID means you have it, you resolve, and 3 months later it comes back. I think that's not it, correct? Long COVID means symptoms just never resolve.
This means persistent symptoms that don't go away, that are still there 3 months after. It's kind of what most people that I've seen define it as. So it's not like being reinfected. You know, if you got better and then 3 months later had another episode, that could potentially just be a second infection. These are people who got sick but never completely recovered. So they may be much better. Let's say they're on a ventilator for a while, but you're now looking at 3 or 6 months or a year later, and they're still not back to normal. They're having a lot of people have a brain fog or fatigue or chest discomfort, something that shouldn't be there, that's lasting for a long time. So yeah, not people getting better and then worse, but people who just never quite completely recover. This next slide is a poor quality slide. I tried to screen grab it off the talk from Mayo Clinic I was looking at yesterday, and it didn't do a very good job, but I'll explain it. This is kind of trying to talk about kind of how the long COVID works. You can't read that very well, but the green curve is the nasopharyngeal. This is like how you would culture the virus in the nose. So you'll see that before symptoms start, that those titers start to rise, and then they kind of peak about the end of the first week, and then start to fall off, and by a few weeks out go away. In the lungs, which is the purple number, you can't see it very well. It says viral isolation of the respiratory tract. Is a much shorter course. It'll kind of come up and go back down. But then a lot of people on the right side are the ones that this is the long COVID stuff. So you're already at that point, you're negative. So the PCR positive test would only last a few weeks. They're completely negative at that point. So this is not a viral problem that's going on as far as we can tell. So it's not like these never cleared the virus. But this is all the problems they'll be getting. This is the fatigue, poor quality of life, dyspnea, cough, and so forth. And basically all these symptoms occur in about 10 to 20% of people who have had COVID-19. And again, you're no longer positive. So it's probably more an inflammatory response or something else that the virus triggered, as opposed to the virus hanging around for that long. So in America, you know, how much COVID fatigue are we having? and how much are people worried about getting COVID over the next year or so. This came out of the New York Times a couple of weeks ago, and they broke it down by age group. And you'll see that about a quarter to a fifth of people are very concerned, but a lot of people, probably over a third to getting close to 40%. A lot of places either are not concerned at all or not too concerned. And this is one of the problems, because I think we're getting, and rightfully so, we're getting COVID fatigue. People are just kind of tired of it. People are tired of wearing masks. They're tired of being socially distancing. Unfortunately, being tired of it doesn't make it better. But anyway, and people say, well, it's not that big of a deal. We've kind of gotten over the worst of it. Well, maybe we haven't. This is how things look last year compared to this year. And you'll see that the numbers of deaths, the number of hospitalizations, especially the number of cases, have just skyrocketed compared to this time last year. A lot of that is because Omicron this time has got much more infections, because like we mentioned, that R-naught number that's like 10 as opposed to 2.5 or 3. Luckily, it has a lower absolute risk of hospitalizations or death, but because there are just so many cases, so many more cases, even a lower percentage of hospitalizations and a lower percentage of deaths, there's going to be an increased number compared to last year. So that's why we're still having problems with hospitalizations and deaths, is just the sheer numbers we're getting with. And then you also say, okay, we're a very, we developed the vaccines, right? So we are a very rich country, so we should be doing better than the rest of the world because, we're America. Well, guess what? We're not. Okay. This is looking at the cumulative deaths per capita during Omicron. You'll see that the countries in Europe and so forth had their issues, but nowhere near as much as we have. The cumulative deaths per capita in the United States is much higher than Canada to the north of us, Australia, Sweden, and all the countries in Europe. In fact, the vaccination rates in Portugal, which is one of the most vaccinated countries in the world, the COVID deaths haven't risen much at all, even as the number of cases surge, because they have so many people vaccinated. Unfortunately, here in the United States, vaccinations have somehow become kind of a political statement. And with our lower vaccination rates compared to places in Europe, we're seeing the effects of that with higher death rates than they're seeing in Europe. This is who's at risk. It's the unvaccinated. This is data, again, from the New York Times, based throughout the United States. And the average deaths per 100,000 people for unvaccinated, 7.8. Vaccinated but without a booster is 0.6. And for people who have been vaccinated and boosted, the rates are 0.1. So 0.1 per 100,000 versus 8 per 100,000 by getting your vaccination and boosters. So hopefully we'll get people to get vaccinated and boosted to help all of us. Okay, enough about that. We'll kind of wrap up things for a little bit here with talking about the diving, which is what we're all interested in. So common questions would be, can we spread this virus underwater? How do we disinfect our gear? I talked both about those last year, so I'll go through that quickly. How do we safely resume diving? And then when can someone return to diving if they've had the disease? And kind of what the latest recommendations are from the UHMS, and UC San Diego has done the major paper on this. Can it be spread underwater? We don't really know. Most of the data is based on SARS-CoV-1, which is very similar. That's the original SARS virus. And that we find that any kind of chlorinated pools or hot tubs inactivate the virus. So if you're doing scuba training in a chlorinated pool, you're not going to pass the virus by changing regulators or not having things sterilized. The virus can be infectious for long periods of time on the surface water of lakes and rivers, and we have no data whatsoever for salt water. If you're going to disinfect your gear, prior to March of 2020, I'd never heard of the EPA list N, but the EPA list N, you can look up, you can Google it, is a listing of all kinds of disinfectants, what they have been proven to kill, and how you apply them in terms of the duration and the concentration. So currently, these are the products that have been shown to be effective against COVID-19. There's two types of Maticide, Maticide 1 and Maticide FD. There's two types of Simple Green D Pro 5 and Simple Green Clean Finish, and Viricon, which is one of the ones we use in rebreathers. Interestingly, Stearamine, which is the most, I'm a rebreather diver. I've kind of drank the Kool-Aid, so I dive almost entirely rebreathers. Stearamine is not on the list in, That's really, though, because it hasn't been tested. It probably is effective, but it's not on the list in. So if you wanted to be really scientific about it, I'd use one of those other kind of products to clean your gear. You can use bleach, but bleach is very toxic. If you're going to do that, it's a third of cup in 1 gallon of water, and you leave it in contact for 1 minute and rinse and let it air dry like you would everything else. The other thing to be aware of is you want to be careful not to reinfect the gear. So if someone is infected, not knowing it yet, not wearing a mask, and you sterilize your rental gear, and the guy who's infected is putting it back up on the rack, you could reinfect things from that person. So you just have to be very, very careful about that. As far as safely resuming diving, for dive centers, what we've seen over the last couple of years is trying to have fewer people in classrooms and pool sessions to spread, so you don't have as much a great likelihood of spreading the virus. Just like this conference, lots and lots of things have gone to online training. So lots of Zoom conferences, lots of online training, e-learning, and so forth. And if you're in a dive center, you need to make sure you disinfect items touched by customers. We say the reason to buy a mask is because it fits. So people put it on their face and make sure it fits. Well, if they do that, you need to have somebody in the store making sure that mask gets disinfected before it's put back up on the shelf for somebody else to try within a few minutes. I don't know what they're doing in California because I have not been diving in California since this started, but I'll tell you that here in Florida, when the pandemic started, we were shut down. Once they opened back up, the requirement was for face masks to be worn by all crew and all guests. I will tell you that has kind of fallen by the wayside over the last year or so. I guess you all know, though, that Florida has been pretty wide open, kind of the wild, wild west here. It's not been a real problem, but that's changed a little bit. They have fewer divers in general on boats. They don't have them as packed as they used to. The community mask bucket of rinsing your mask is gone. That's either done with a hose or done in the salt water, but not done with a community mask bucket. And what the way they tell the divers they should do is that all divers should be wearing either face masks on the boat, or when they get under the gear, would have face masks and regulators in their mouth when getting out of their spot, then off the back of the boat, or returning to their spot after the dive. Again, trying to limit the spread among people on the boat. Probably in a windy environment, that's not likely to be a real problem. But again, just they're trying to be safety conscious. And then lastly, what we're doing in Florida, at least, is currently the dive staff get all the drinks and snacks and so forth for the customers, as opposed to multiple people touching coolers, using water jugs, snack containers, and so forth. So that's kind of what we've been doing here in Florida, at least. International travel. I know I was talking to Ken right before this, and he mentioned how he hadn't been out, hadn't done an overseas trip in quite a while. Travel restrictions are varying by country. As we all know, some borders remain closed. Some have opened and have recently closed again. Many, if not all, countries are requiring a negative test for entry. Some of those may be antigen tests, but the majority are PCR tests. You need to make sure you have the proper test for the country you're trying to get into. Some countries are still requiring quarantine upon arrival. Sometimes that's not too big of a deal. As an example, we went to St. Lucia, and you had to be quarantined. You couldn't leave the resort, but we weren't leaving the resort anyway, so it didn't really matter. We could hang out in the resort and dive and enjoy the amenities, just couldn't travel around the island. Other places require additional tests during your visit. I just talked to Joe Makudowicz, who owns Dive Tech in Grand Cayman. The Cayman Islands are quote unquote open at the moment, but you have to have a negative test to get on the island. And then you have to have additional tests on day 2, day 5, and day 7 of your visit, as well as 24 hours before you return back to the United States. So the USA used to require a negative test within 3 days of air travel. Now it's down to 1 day, so you're a little bit stressed. We were in Mexico at Cozumel over New Year's. We were flying back like on a Wednesday, so Tuesday afternoon we had to go get a COVID test and hope that we got it back quickly, and we hoped it was negative because we're supposed to be flying the next day, so it's always a little stressful. And like I said, be aware of which test is required for each country, whether it's a PCR test or a rapid antigen test. And then lastly, because people say, well, I'll take the chance, I don't mind getting tested and so forth. Even if you're healthy as you leave the United States, you could have been infected and just not developing symptoms yet. And so even if you're healthy as you leave the United States, there are a lot of great locations for diving that are not great places to get sick or great places to get quarantined. So one of the things to think about with your international travel is, what if I get sick on vacation? What is that going to mean? What is my medical care going to be? What is my options as far as getting back to the States? If I get quarantined, where am I getting quarantined? What kind of, quarantine? Is this a government place, which happens in some countries, or can you stay at a hotel? To other countries, how much is this going to cost? You're probably going to be the one paying for it, unless you've managed to find an insurance policy that's got COVID coverage. So lots of things just go into your decision when you get ready to travel. So you should ask yourself, first off, is travel safe, responsible, and permitted between my home and where you're going? Would there be some quarantine required at the start or end of the trip? And how would that affect your work and family life with that? Would I need to get tested when I get back to the States? Is that possible where you live? And then what about particular business closures from all the problems with COVID over the last 2 years? What would that mean at your destination? Like what places are still going to be open? What's going to be closed? What kind of supplies you're going to have, and so forth. Another question would be, like I mentioned before, what if you get sick somewhere? So you go to a particular country, what are the medical options at that location? Will your medical coverage work there? Do you need to have some additional coverage for COVID? And then again, what happens if you can't fly home? What if you end up getting COVID, or you test positive but are asymptomatic? Or what if there's another border closing? What are you going to do at that point? And then finally, does your travel insurance cover COVID-19? And most of them do not. You need to really look at the fine print to see what would really be covered in your travel insurance. So what should we all do for ourselves? Obviously, try to stay healthy, try to stay fit. If you start to get sick, please don't dive and take the chance of either hurting yourself or hurting somebody else. Obviously, we should all practice good hygiene, maintain, disinfect your gear, heed the travel warnings, and just try to manage your risks as best as you can. If you're going to travel, realize, like I mentioned before, that a lot of travel insurance does not cover pandemics and viruses. So you're going to need to read the fine print on your travel insurance. At the airports, if you guys have not been to airports recently, you're going to need to bring your own drinks and snacks for the flights. There are no meals on flights anymore. That includes, business. I'm not sure about first class, but at least in business class, there definitely are not meals. You're going to need to arrive early because there may or may not be delays because of the staff out for TSA because of positive tests. And masks are mandatory during the flight unless you're eating or drinking. And they're very strong on that, and rightfully so. What about liveaboards? One of the things we really like to do is go on liveaboards. So think about that. That's basically like being on one big petri dish. So where should you go to minimize? How should you kind of minimize the health risks? One thing to think about is kind of where that liveaboard is. If you guys are in California and think about doing a liveaboard in Hawaii, that's one flight. That's fairly easy. If I'm in Florida and planning on doing a liveaboard in Raja Ampat, I'm going to probably have to fly through Canada, then through Hong Kong, then through a couple of places in Indonesia before I could get on the boat. And there's multiple contacts through multiple airports is going to probably increase the risk. So you may want to consider destinations that you can get to easier and not be through so many different airports and so many connections just because of the crowding and likely to being exposed to someone with the virus. You want to know kind of how your particular operator is cleaning and sanitizing the boats. And then how is it possible to maintain any kind of social distancing on board? Are they filling up the boats? Are they have fewer guests? What are they doing with meals? There was a time when a lot of the meals they were trying to serve outside. And a lot of the companies just trying to get business on board were decreasing the single supplement. So divers didn't have to share cabins with people they didn't know. So if you're traveling alone, rather than match up with somebody you don't know their vaccination status, they decrease the single supplements. I'm not sure if that's still going on or not. And then, like I mentioned, what's the quarantine policy if a guest tests positive? That was the question that kind of came up for my wife and I on our liveaboard trip we had planned for April. And the problem was we don't know the people on the boat. It's not like we had booked the whole boat, so we knew everybody that was going. So we don't know who's going. We don't know what their vaccination status is. And if somebody, not even ourselves, were testing positive, we could potentially get stuck in the Maldives for an extended period of time. So we opted to just cancel that trip. And that was just our personal decision. What if you start to show symptoms? Definitely cancel. Please do not go on a trip when you're sick. Again, because of the virus and because of the pandemic, many operators are much more flexible regarding cancellations and rebookings than they were. Another example of that is my wife and I were going to be going to Norway in November of 2020 for her birthday to snorkel with orcas. And that was right smack in the middle of the pandemic and shutting down of Europe. So that trip was moved first from November 2020 to November 2021. Then we had Delta. So now that trip has been moved from 2021 to 2022. And still all we've had to pay was just our initial deposit. So there are a lot of places very flexible and very realistic about what's going on and trying to work with you as best they can. Here are some travel resources. This is all being recorded, so if anybody needs this, they can look it up and get these. This is various ways to look at what travel restrictions are out there, how to get travel advisories and so forth for a variety of different ways. This again, Ken will have this so you guys can get this if you need it. Okay, so what can divers do? What can we do to try and help keep ourselves safe, keep other people safe, and get back in the water and do the thing we love? First off, I would strongly recommend people please get vaccinated and boosted. That will markedly decrease your likelihood of being infected. If you are infected, you'll have a much greater likelihood of having a very mild disease, and you'll be much less likely to pass the disease on to somebody else. Wearing a mask is important. Initially, the N95s, KN95s were very good, but a lot of people weren't wearing them because they're not quite as comfortable as just cloth masks or face coverings. And the day of Omicron, that is so infectious that the simple masks probably are not very helpful. So I'd recommend people try to go to an N95 or KN95 while we're in this Omicron wave. Social distancing obviously is quite helpful. Get tested, and who should get tested? If you have any symptoms that you're concerned, please go get tested. Or if you're exposed to someone who tests positive, it's a good idea to test yourself just to make sure you shouldn't be quarantining as well. But people say, yeah, but I'm young, I'm healthy, I'm not going to get sick. Why should I bother with all this? Well, I tell people, please don't be selfish. I mean, try and think of others. Vaccinations, boosters, masks, social distancing, what that does, it does decrease your likelihood of being infected. If you do get infected, the disease is much more likely to be mild. You will protect others from being infected. I'm not saying you're going to prevent it, but you will help protect other people from being infected. But also think about the population at large, and this is coming from someone in the medical field. Fewer people getting sick means you're going to have fewer people in hospitals. You have fewer people in ICUs. So hospitals are not going to have to cancel elective procedures due to hospital occupancy or staff shortages. That's what we've seen. So poor people can't get their hip surgery. They can't get their elective, any kind of surgery done because there's just no beds for them to go to. And if you want to see people who have really just been pummeled by this pandemic, go in a hospital and look at the nurses, look at the techs, look at the critical care doctors. They're just so incredibly overworked and burnt out from all of this. Anything we can do to keep people out of the hospital is going to help our whole society. So anyway, that's my little soapbox, and I'll get off of that. So what can we do? We're in the age of an evolving pandemic. Well, first off, your local dive shops are having problems, so please support them. You're not traveling, maybe use this to kind of upgrade your gear that you haven't done. You spend some money with them there. Sign up for some new classes, whether it be diving classes or non-diving classes. Just kind of spend some money, develop some new skills. Dive locally. Ken and I were just talking about this before we got started. Even if that means purchasing a dry suit. There's some very great diving outside the tropics. You guys have phenomenal diving in California. Obviously, it's cold. And if all you do is go to the tropics in a 3-mil wetsuit, you're probably not really excited about your local diving. But if travel's not possible and you want to dive, it's probably worth putting that money into a dry suit and enjoying all the things that you can see there in California. Additionally, think about investing in long-term training. So while we're in the middle of a pandemic, you can make the purpose of your diving to be something as opposed to seeing something. So, if you're not an advanced open water diver, take an advanced open water course. Take an intro to tech course. Take a solo diver course, okay? Heck, be like me. Like I was joking, I took an ice diving course last February. I learned a bunch of new skills I would not have otherwise had. Anytime you're in new environments and new training, you'll become a better diver. An example is, think about this just realistically. If you've took a diver who had 500 dives, but all they'd ever done was in the same quarry with the same people versus somebody who'd only had 100 dives, but they'd been in a wide variety of environments, a wide variety of conditions with a wide variety of instructors and divers with them, that's going to be a much better diver. So anything you can do to put yourself in new environments, new training will result in you being a better diver. If you're concerned about the crowds, you're concerned about infecting people or getting infected on a liveaboard, try shore diving. Again, California, you guys have lots of good shore diving. It may require a dry suit, but you've got lots of good shore diving. And please, if you've had a long layoff from diving, take a refresher course. You do lose skills. It's always recommended if people have more than about a 6-month delay in diving, that they've been out of the water, please take a refresher course, again, just to make yourself safe. All right. What about if you get sick? What about quarantine guidelines? We're almost done here. Quarantine. In December, the CDC shortened its recommended isolation period. It's recommended now that people can enter society after 5 days of isolation rather than 10 if they have no symptoms or if their symptoms are resolving. It's then recommended they wear a mask for an additional 5 days. There's no requirement for a negative test to get back into society. And the difference is there's no difference whether you've been vaccinated or not vaccinated. So people say, well, that sounds like, why would they do that? The real reason they're probably doing this is when they had a 10-day recommendation, people weren't doing it. People just weren't staying at home for 10 days. So the time you're most infectious is those first 5 days. So the hope from the CDC was by dropping it to 5 days, maybe they could at least get people to follow that recommendation and stay out of society while they're the most infectious, and then wear a mask those last 5 days. That's really kind of where that guideline probably came from. All right. So here are the guidelines. This is the last of the slides. It's a little busy, and I'll kind of give you kind of the overall. This is from UC San Diego. Basically, they break them down to 4 different categories. If people are asymptomatic, so you just had a positive test because you need to get tested for something, but you never had any symptoms, those people really don't require any additional testing to get back to diving. Wait till you're back in society and you can return to diving basically with no further testing. If people had mild disease, so they were home, they quarantined for 5 days, they had mild flu-like symptoms, they did not have to go seek health care, and it was outpatient treatment only. They did not have low oxygen levels. Those people should stay out of the water probably for about a month to get completely back to normal. And since this is mainly a respiratory disease at this point, it's recommended people get a chest x-ray. If that's normal, they could probably stop there, maybe with some spirometry, which is lung function test, to make sure that their lungs are really working well. If there's anything abnormal in the chest x-ray, they should probably move to a CAT scan. If their exercise tolerance is not ideal, it would be a very good idea to do an exercise tolerance test with oxygen saturation. So a little pulse oximeter on your finger and making sure that your oxygen level stays good when you exercise. That's what I did back almost 2 years ago now. When I thought I was back to normal, remember I mentioned I got back on my rowing machine. It took me another couple of weeks to feel back to normal. Before I got in the water at work, I just put myself on a treadmill with a pulse ox, jogged on the treadmill for 10 or 15 minutes to make sure my oxygen saturations were still good. And then at that point, I was willing to get back in the water. If people have more moderate disease, this is people who required some supplemental oxygen or had an abnormal chest x-ray or CAT scan at baseline or were actually admitted to the hospital but didn't end up in the ICU. Those people should definitely have a chest x-ray, and if abnormal, a CAT scan, should definitely have spirometry, which is lung function testing. And because of the more severe disease and the incidence of having cardiac involvement, it's recommended the patient get an EKG and an echo and ultrasound test if they did not have that done while they're in the hospital. And the same sort of thing with exercise tolerance with oxygen saturation. Finally, people had severe disease. These are people who are intubated on a ventilator. They should stay out of the water for a minimum of 3 months. And then slowly get back to normal. People who are that sick probably wouldn't feel up to diving for 3 months anyway, but should wait at least 3 months. And they're going to need a full workup before getting back in the water. They'll need the spirometry, the chest x-ray, the EKG, echocardiogram, exercise tolerance test. And also if they had elevated cardiac enzymes in the hospital, like an evidence of myocarditis, those should be repeated to make sure they've completely normalized before they ever get back in the water. So conclusions, COVID-19, it's a coronavirus, which causes about 15 to 30% of the common cold. This one, though, is a very serious illness with a mortality rate that's at least 10-fold that of seasonal flu. The vast majority of people have no or mild symptoms, but a small percentage get very sick or die. It is spread by respiratory droplets. So the best things we can do are wearing masks and social distancing to keep those droplets from infecting one another. And people who are at high risk or elderly, you saw how the mortality rate jumped dramatically in the elderly, should shelter in place as much as possible. And then as restrictions have been lifted, as you would expect, we've had an increase in the number of cases. When considering dive travel, consider your medical care and your return travel options should you get sick on vacation. And returning to diving should be possible for almost all divers who've suffered COVID-19. However, it's recommended that you should be asymptomatic and return to your normal baseline level of fitness before even considering going back in the water. And that especially if you require treatment and definitely if you require hospitalization, you should be evaluated by a physician knowledgeable in diving medicine to decide if any further testing is needed before you return to diving. And that's all I have. It's been about an hour, so I'll see what you guys have in terms of questions.
I'll bet they're going to have a bunch. Why don't you unshare your screen?
Yep.
And I'll let you guys know, by the way, I've dropped into the chat, and I think this may have been what you're referring to, Doug. You'll see in the chat, there's a thing called DHMJ-50-278. This is a paper from UC San Diego, Dr. Karen Van Housen and Charlotte Sadler and others.
That's it.
And this has the charts that Doug was referring to in terms of how you determine you're a 0, 1, a 2, a 3, or a 4 in terms of your severity. I guess if you die from this, you're a 5. And 5,
right,
we
exactly.
We don't,
you don't need any further testing.
Don't need any further testing. But it also, there's 2 charts in there. And the second chart is, as Doug was mentioning, what are the tests you might have based on your severity in terms of being able to return to dive. So good stuff. And if for some reason you can't download it from the chat, send me a note at kencurtis@aol.com, and I can just attach it to an email back to you. So for those who have questions,
let me get one thing real quick.
Oh, sure.
I think why you have to bring that up. The diving medical changed during COVID-19. We went to a much more simplified form rather than all the questions, the hundreds of questions you had to yes or no anytime you took kind of a continuing education. Unfortunately, with it coming up during the middle of the COVID, the first question now is, do you have any cardiac pulmonary issues, or did you have COVID-19? So with this, everybody's checks basically COVID-19. So almost everybody has to get seen by a doctor to clear that medical, which is a little bit of a problem. I just found out 2 days ago that NAUI has changed their form. And that form now, they took the COVID-19 part off. That has not been taken. I checked with SDI, TDI today. I heard back from them. They have not changed theirs yet, but they're waiting for recommendations. I also reached out to INTD and SSI, but I've not heard back from them. I'm not a PADI instructor, so I didn't reach out to PADI, but just know that has been a problem because that was a question. There wasn't, people had COVID at the time they made that new form. Now, obviously, with this infection, especially with Omicron, lots and lots of people are having COVID. So lots and lots of people are going to have to get cleared by their doctor to dive. So hopefully they'll take that off if they've not had severe disease. But anyway, sorry about that.
And interesting. I'm a NAUI instructor, and
okay,
I didn't get no stinking notification about that changing.
It's on the website. Yeah, it's on the website.
Oh yeah, because I go to that NAUI website every day to find out the latest things that are going on. So what we can do here, everybody, if you got a question, you can either use the little raise hand function down there in the reactions, or actually physically raise your hand, whatever works. But I see that Ilan Tamir has put a question in the chat, and I'll let you know Ilan is a physician, and he's asking about effectiveness of booster shots. That some people got them as much as 6 months ago. Effectiveness goes down. What about a second booster, especially for senior divers in Israel? They give them to people who are over 60 for the last 2 months. What do you think about that?
You're right. In Israel, that worked. The data I've seen for the U.S., they looked at a 4th shot and found it was not effective against Omicron. So for the particular wave that we're in, it was not effective for us in the United States. I've seen the same data from Israel, so I think that's debatable. And here in the States, they tried to look to see if it was more effective by adding a second booster, and it was not.
Okay, and I would wonder, any speculation on your part as to why the monoclonals don't work against Omicron? I got monoclonals, and I was at the tail end of my infection, but whatever little residual symptoms I had, I'd say 6 hours later they were gone. So for Delta, which is what I assume I had,
right? I don't know why that would be, except it may simply be somewhat's going to be risk benefit, cost benefit. That Omicron is obviously a much milder illness than Delta. Monoclonal antibody therapy obviously is fairly expensive. So the question is it it worth putting that much resources into something that has such a low mortality in general? And does the risk benefit ratio really favor that or not?
No, the answer, Ken, this is
Yes.
Susan. This is Susan.
She's a doctor too. Just
Well,
Oh,
not
good.
only that, but I have a master's degree in immunology. So,
Oh, even better.
like you
The
know
Delta-
something.
well, I might, doctors would. It's anyway. It turns out that the Omicron is a very different from all the other variants we've had. It actually has like over 15 mutations in the area that it binds, and those mutations stop the antibodies from getting to the binding site. The neutralizing antibodies have to bind to the part of the spike that latches onto the cell. And it has so many mutations, it's gone and mutated all the way around, and it still binds, but our antibodies can't get to it. And so it can't block it. And that's why the monoclonals do not work, because most of them were against the area that binds. And Omicron put up a little fence around it so that our antibodies don't bind. So that's why they don't use the monoclonals.
Right. You know the difference with the GlaxoSmithKline, because apparently that one is still effective.
Yeah, it is effective. It just happens to be an antibody that gets to a part of the spike that and that's why there's so many breakthrough infections, because we got the immunizations that were against the original spike. And so a lot of our antibodies don't get through to that area, but Omicron has so many mutations right in that area that many of them, and that's why they stopped it, because in the dish they tested all of the antibodies that you could give, and they said very few of them bound enough to help. So that's why it wasn't necessarily the cost, it was the fact that even if you're very high risk and they're afraid you're going to die from Omicron, it doesn't work because of the way that the Omicron has mutated. So that's the reason. I can send some, if you want them, I have some references on that.
Documentation.
That's great. Thank you.
Yeah.
And in case you guys are wondering, that's Susan's husband, Lionel, whose picture you kept seeing, because they have their video off. She's not wearing glasses with a beard there. So, but she's been a doctor for a long time, as well as a long time diver too. So thank you, Susan. And if you want to forward anything to Doug, just shoot me a note, and there she is. Here, Susan, say something so they can actually see you. Oh, she muted.
That's me.
You're muted.
There we go.
Yeah.
But if you need to send anything to Doug, send it to me, or I can send you his email or whatever works. What are the questions we got, if any? This is the questionless group, most questionless group we've had. I knew I could count on Glenn.
Yeah.
All right, Glenn.
So I'm assuming it's fairly important to get in shape. And I've been starting to go to the gym lately, and I've noticed that the people in the gym tend to be those 40%, 40%ers. Any suggestions about how to deal with that? Or
You mean that? Are you talking like 40% who have not been vaccinated? Is that what you mean, or not wearing a mask?
Well, actually, I just got my 4th vaccination today.
Okay. No, you're saying with the people, you're saying there's a lot of people who you think are not protected. Is that what you're saying?
Yes,
Okay.
yes.
Yeah. Two aspects of that. First off, congratulations for, commend you on getting in shape. I've been an instructor for a long time, and I tell people you don't scuba dive to get in shape. You get in shape to scuba dive, because if you get a lot of exercise scuba diving, you're probably doing it wrong. So first off, obviously, I think it's very, very good. And along those lines, just while I've got a soapbox, as we get older, we should all do 3 forms of exercise. We should all do some cardio. We should all do some sort of resistance training, and we do some sort of stretching. So whatever, Pilates, yoga, whatever. The thing, I don't know how your gym is designed. The way our gym changed in 2020 was they spread everything way out. So none of our machines are within 6 feet of another machine. So the respiratory droplets shouldn't travel more than 6 feet, even if you're huffing and puffing. So at our gym, at least, all of the machines are aimed away from each other. There's no machines aimed at each other. So everything's aiming up against the wall, and they're separated by 6 feet. So what I would do is wear your mask. I would wear your mask while you exercise if you can. If it's difficult to breathe, you can take it down when you're really exercising and then put it back on. So whatever you can do to socially distance and maintain masks, that would be the best thing. If you're very concerned and you don't think that your particular gym or the one you have to go to is protecting things very well, then I'd find some way to exercise at home. Peloton did great during the pandemic. They're not doing so well right now, but during the pandemic, they did very, very well because people developed a lot of home gyms. So, something you could do outside, out away from crowds, something you could do in your home, or if your gym, if it's got a way of, protecting things, like I said, spreading machines out, keeping them away from each other, and you wearing your mask is probably about all you can really do.
And to touch on two points, when I do the blurb, my hand sometimes goes away. Two other points to touch on what Doug just mentioned with the exercise at home. One of the things I like to do at my gym, because it kicks my ass, is one of those stair stepper things. And I haven't gone back to my gym for a couple of reasons. But then I realized, I live on the 3rd floor of an apartment building and I have a stairwell right outside my door. So every day I do 10 sets of 2 flights of stairs. I do 20 flights of stairs, and that helps keep me up. Now, the other thing is, for those who don't, and I'm one of these people, I really don't want to go to the gym and wear a mask while I'm exercising. But there was a photo going around today, and if anyone wants to burst my bubble and say, it wasn't true, but it's the women's Canadian hockey team at the Olympics, and they apparently played their last match, all of them wearing KN95 masks for the entire game. So the point was, if they can do it while playing hockey, you can do it at the gym.
Right. Well, they're obviously in much better physical condition than the majority of us are.
No,
as well.
I doubt. No. Any
Robin's
other questions we got?
Robin's hand's waving. I see her.
Oh, cool. Robin, you're up.
So Douglas, maybe Susan. My husband and I have these special masks. They're almost like a respirator. They have an internal fan and 2 HEPA 13 filters. And, I'm just not sure, because it does have that internal fan and you can breathe and exercise. Is that safe to use?
I would, if you've got HEPA filters, then I would think so. If anything, that's probably overkill, but overkill is never a bad idea.
Okay.
But I also think if you try to get on a plane with those, anything that's got any kind of a filter or a hole is a no-go.
Yeah, that's a good point. I should have brought that up. They will not let you on a plane with any kind of mask that has a vent.
Initially, when we went to French Polynesia, they were objecting, but we said they're 2 HEPA 13. My husband took the filter off and showed him it was not open. It was a closed circular, and they let us on. The supervisor got called over, I think, on the way home, but on the way there, they let us on, and then the supervisor let us on the way home.
Yeah, there are some N95 masks, or looks like N95 masks with a little filter to kind of make it easier to breathe, and they won't let you use that on a plane. You have to put a mask over that mask for them to let you on the plane.
Yeah, these are plastic and pretty heavy duty.
Other questions? Alan,
Yeah.
a fellow Northwestern graduate. The Northwestern education comes through.
There we go. We're going to be talking right about that right now. Doug, first of all, thanks for really a great and informative presentation. Really, I really feel like I got a great education tonight. So thank you. One thing that I noticed, I'm preparing to do some international traveling. And one thing, I think, a clarification about the US requirements coming back to the United States. First, the 24-hour rule, I think, is not actually 24-hour. It's 1 calendar day before. So if you have a 3 p.m. flight, say on Saturday, it doesn't have to be, you don't have to be tested at 3 p.m. on Friday. It has to be sometime on Friday.
Right.
So
The way
the
the actual wording on the CDC website is within 1 day of travel. It doesn't say within 24 hours. It does say within 1 day So that's probably open to interpretation, but it doesn't. I just looked at the CDC website right before I got on the talk tonight just to see if anything had changed. So that's how the wording is. But yeah, you don't have to have it within 24 hours. If you're flying at 3 in the afternoon, you can probably get the day before at 8 o'clock in the morning.
Yeah, that was my reading of it too. And just another point of information, they can be certain kinds of rapid antigen tests are acceptable by the CDC. Doesn't have to be PCR per se. So for example, Abbott Labs, the Binax test that they do, they have one that you can do from your place. You don't have to actually go to a laboratory. And for some airlines, not all airlines, they have to have an affiliation. But you can do a video observed testing of a rapid antigen test in your room or house or whatever you're renting, wherever you are, and they will certify you for your airline. I think United has it, American has it. You have to check with the airline, but there are ways besides, waiting in line at a laboratory in some remote place to get your, certified testing to be able to get back to the United States.
True, but I'll tell you that most of the resorts are aware of that. I've only been I've been to Cozumel twice, to St. Lucia once, and to Honduras once. And all 4 of those, they had that set up for us at the resort. They tried to make it pretty easy for you. So basically they had a room, you signed up for a time and just basically kind of roll by, and it took like 10 seconds. So they were, luckily, at least the places we've been, didn't make you go somewhere in town to some center. They tried to make it easy for you. So I think your points are very, very good, which would be find out by your airlines what they require, so you make sure you get the right test. And then wherever you're going, check. One thing you want to check is say, I got to have a test to get back to the United States. How am I getting that when I'm there? What are you doing to accommodate that? And if one hotel is doing it and one is not, then maybe you stay at the one that makes it easier for you. It's all,
right.
All that sort of thing. But yeah, very, very good point. It's all a matter of finding out what the rules are, and the rules change on a weekly, if not more shorter time frame. That's why I checked. Like I checked the CDC thing tonight right before I logged on, just to make sure nothing had changed since I made the slides.
And
changed
Alan,
since.
I think also the key thing with what you described is it has to be an observed test that, it's done through the web or through your phone or whatever, not just like I've got a bunch of, rapid antigen tests, sitting 5 feet away from me, but those wouldn't count because there's no medical professional making sure you do it right to vouch for you.
That's right.
Right. And there's your test.
Yeah.
Binax actually sells as a different color box.
Yeah.
And it actually sells that you bring with you on your trip, and then you connect to them and have it observed. Exactly. That's a great clarification.
Yeah. But God forbid your Wi-Fi goes down. Yes, Robin.
Oh, I just wanted real quick. This is from
that's it.
Atmo Blue. And then these are the 2 HEPA 13 filters, and there's an internal fan. So we showed them that it's just a closed system, and they let us on the flight with it. Atmo Blue, if anybody cares.
It's cool.
Very
It looks
cool.
like when you put it on, you look like a giant ant that's, come out of a nuclear explosion or something. Glenn.
Actually, there was do you guys know those goofy snorkel masks that have the full face snorkel thing that kills
Yeah.
people? People were making little filters for the tops of those. And we actually had one of the cardiologists for a few months wearing one of those snorkel masks in the hospital every day with a little HEPA filter kind of connected to the top. So maybe there's a use for those kind of masks.
There's a great picture of somebody in Walmart wearing a snorkel and a mask, and they're saying, the caption is unclear on the concept. And Doug, there's something on the right side of your camera.
Oh, okay. Gotcha.
There it goes. There you go. Glenn, you had Elon.
Yes.
We're going to go to Elon. We'll go to Elon. Let's go to Elon first, and we'll come back to you, Glenn.
Oh, okay.
Elon, go ahead.
Yeah,
Another physician.
I brought it to Ken's attention. I've been with my son. We went diving to Bonaire in mid-November, and we flew from Las Vegas to Houston, layover 15 hours overnight in Houston with a connecting flight. And when I checked with United, I even spoke 3 times with the supervisor. They assured me that the COVID test, PCR for Bonaire, has to be 48 hours from the first embarkation point, which was Las Vegas. When I checked the 5th time, I was told that by United, they did a mistake. They verified it, that it's 48 hours from the second flight, actually from Houston. So people have to be aware of this. If you have a connecting flight, that's at least for Bonaire, more than 12 hours, you stay overnight in a place, it is that 48 hours start from your second flight, not from your first flight. So just be aware of this because you can get into trouble.
Right. Again, got to check the rules, and they change all the time. That's a very good point.
Yep. Glenn?
So I'm going on a trip with you, Ken, to Socorro's, and I got travel insurance, but it cost 1/5 of my total trip cost.
Oh, you mean travel insurance that would be willing to cover COVID?
Yes. It's actually a cancel for any time. So the trip cost $5,000. The insurance cost almost $1,000.
And I'm willing to bet that the higher cost is because of the cancel
Right.
for any reason, as opposed to the COVID.
Right. But they wrote that there's day and age, that's probably why people are going to cancel for any reason. But that's expensive. That's expensive.
Yeah. And for
Let me, there are different insurance companies that have different pricing.
Hey, Jeff.
Yeah.
I haven't seen you
how are
since the
doing,
Great
Doug?
Lakes. How you doing?
Good.
I didn't know you were on
anyway,
here.
I'm using travel insured CFAR policies for my groups, and their cost was about 10% of the trip cost rather than 20. So if you shop around, you may be able to find better pricing that still covers COVID cancellation.
And Jeff just came back from Antarctica. So I assume you had that insurance on that trip, Jeff?
I did. In fact, I've been traveling a lot recently, both domestically and internationally.
Yeah.
And in fact, Doug, I sent you a fairly lengthy email with some other points, some of which have been raised in this discussion and some not, for future talks for you, dealing
thanks.
specifically with travel.
And are you going back to Key Largo anytime soon for your
I
super
should
secret
be
thing you
back
can't tell me
down.
about?
I'm trying to get there now. I should be there within a couple of weeks.
Okay, let me know.
Okay, sounds good.
And the other thing for you guys, one I found I used last year on our Socorro trip, because again, for those who are old enough and from the looks of the group, many of us are, if you're on Medicare, as soon as you leave U.S. borders, you don't got any coverage.
Yep.
So I got a travel specific, it was a 10-day policy through, I believe the company was Seven Corners. And it's something I refer people to, is a place called www.insuremytrip.com. But I got a 1-week policy. It specifically included COVID coverage, seemed to be pretty good. And I think for my 10 days, it was a whopping $98. Now, this was a year ago. I looked at it initially for the upcoming trip, and a similar policy now, I think, was around $250. But again, the point is to sort of go back to where you started, Glenn. If you shop around a little bit, depending on what you want to get, how much coverage you need, how long you need it for, you can probably, find something a little bit cheaper.
For our 4-week trip, Ken,
Yeah.
we found the same type of additional medical coverage for about $49. I think it was $49 a person.
And who was it through again, Jeff?
I'd have to look it up. I couldn't tell you that offhand.
Send me a note if you think about it.
All right.
Cool. Other questions?
Read the fine print on that insurance. A lot won't cover if you're on a dive trip.
What policy did you see? Were they not covering for a diving thing, or if
Yeah.
you got sick on a? Because again, have your Dan policy.
Right.
That'll cover you for a diving accident. But COVID on the boat is not a diving accident. So
They may or may not, but
Yeah.
more and more of them are excluding scuba diving as that they won't cover.
Yeah, they call it a high risk sport.
yeah. Well, the way I've seen some people dive, that's appropriate.
Ken, can you hear me?
Yeah, go ahead.
Regarding insurance, a big factor is the age. My son is 38, I'm 77. When we went to Bonaire, I used the travel guard. So the insurance was, for me, almost 2.5 times more than his. When I spoke with the agent, it just says the table and really goes by the age. And it's not just by year. It's really as you become 60 and 65 and 70 and so on, it really goes way up and up and up. Regarding the diving, most insurance companies are covering diving. You have to look at the small print. Usually recreational diving up to 130 or even 150 feet are covered. It's when you exceed these limits, they will not cover. Another very important thing thing to know is that if you have any pre-existing medical condition, you take cholesterol medication, you have high blood pressure or whatever, you're still clear to dive. You want to get your policy either within 21 or 14 days from the first deposit, so they have a waiver of pre-existing condition. So with people who are older or have any little bit of asthma, okay to dive or whatever, it's good to get the insurance early. Also done as the Guardian insurance, the upper level, in which you have extra like $30,000 for medical, which is not related to diving. So you can slip and fall or get pneumonia or whatever it is, you have some coverage with them.
And actually, I just renewed my Dan insurance, and there's now a level above Guardian, and I don't remember what it's called, like Super Guardian or whatever it is. But and what it does is removes a couple of caps, extends a couple of caps. So my pitch to all of you always is, for your Dan insurance,
I always get the max.
get the most expensive one. Get the best one. Other questions? Are we questioned out finally? Lionel's bored. He's got his hand up on his. Susan, you can smack some sense into him if you need to.
We met 50 years ago, Ken. Do you think that I haven't tried?
Yeah, good point.
50 years
Good point.
ago this month.
Good point. Of course, she says that as a dig at Lionel, but she's the one who's stuck with him for 50 years. So what can I say? Okay. Any Andrew, were you gonna throw something in there? No, you look like you're leaning forward, ready. Okay, that's fine. That's fine. Anyhow, if that's the end of our questions, then thank you very much, Doug. Always good information. Hopefully, information you can use to prevent getting sick. Hopefully, not stuff you need to use to deal with your sickness. But given the infectiousness of this, hopefully we're headed in the right direction. But you never know. Next month, March 8th. Our guest speaker will be Mike Lever from Nautilus Liveaboards, and he's going to be talking about secrets of gray whales, because they do a San Ignacio Lagoon thing, and he's now fired up about gray whales and stuff like that. So you'll get a note, but make a note March 8th for that. Again, Doug, thank you very much. It's the witching hour now. It's midnight now in Florida. So
That's right.
probably got to get up to get early to get into the hospital tomorrow. Thank you all very much for spending some time with us here on Zoom Seekers. As I wave goodbye to you, we'll do our big thing where, like I said, it's among my favorite things to hit the button that says end meeting for all. So thanks a lot.
Thank you guys for your attention.
Thank you.
See you next month.